Network, this is Health and Today's Woman with your host, Dr. Kelly Williams. Sponsored by Murfreesboro Medical Clinic.
Welcome to Health and Today's Woman. I'm your host, Dr. Kelly Williams. As always, this show is designed to help women become champions of their own health care. Tonight we're going to take on a topic that lately has gotten a lot of attention in the media, and that's the idea of hip replacement surgery. Now, recently, having had a family member go through this, I'm especially interested in learning more about this procedure, who can be helped, and what some of the expectations are that we should have of this procedure. To help me better understand this, I've invited Dr. Matt Barrett. He is a joint replacement specialist at Tennessee Orthopaedics Alliance at Middle Tennessee Medical Center. So I want to start off by saying, Matt, thank you for being willing to be here.
Thanks, Kelly.
Now, something that's a little bit interesting about you, and I want to kind of start here, is you're trained differently than a normal orthopedist. So I want you to tell me a little bit about what makes you different than the normal orthopedist.
Well, like all orthopedists, we do a 5-year residency in orthopedics, but I had a special interest in hip and knee replacement. So after that residency, I did a fellowship in joint replacement up in Washington, D.C.
Okay, and that makes it a little bit, you spent your whole time in that year just learning how to do special joint replacements, is that correct?
Exactly.
And I know that's one of the things that makes you a little bit different is you kind of get the toughest cases because a lot of people want somebody that's specialized in this area, is that right?
Correct, and the redo type cases are the more difficult cases. That's something I also take a special interest in.
Good, because I want people to realize that as they start looking, I want them to understand that there are these specialists out there that are available if they so choose. Now, I want you to, we're going to put a billboard up here. People don't realize the actual number of procedures that are done. This is 120,000 hip replacements per year. So this is something that's done quite often. But I want you to start off with, you know, who needs this? How do we begin to start understanding patients with joint problems? What type of symptoms are they going to notice to say, you know what, I might have a joint issue?
Well, typically you will have pain localized to the hip area or to the knee area. Sometimes you self-refer yourself to the doctor. Sometimes your family members tell you you need to go to the doctor for it. Sometimes your primary care doctor will tell you. But typically you have pain localized to the hip or the knee, and then that causes you to seek treatment, and ultimately some of those people will wind up needing a joint replacement.
Now, not all of them, and I think that's important. Not everybody's going to end up needing joint replacement, is that correct?
Correct.
And so, you know, what are some of the other options other than surgical options that these patients may see before they ever get there?
Well, surgery is always a last resort. You start off with non-surgical things, and that's things like activity modifications. So if you know you're running excessively, you may have to change. You may have to start cross-training or things like that. So activity modification to start. Things like braces sometimes are helpful with knees, for instance. Medications are helpful, and we often give patients anti-inflammatories to help with arthritis pain. Injections can sometimes be helpful, and we can do those in the hip or the knee. So there are lots of things that we try prior to surgery. Surgery is the last resort. Now,
a lot of people see orthopedic surgeon, as I always say. It's kind of a, you know, obviously you're going to operate because you're an orthopedic surgeon. When do they need to come see you? Do they start at you or do they start at their primary care?
I think either way. You know, quite often patients will start at their primary care doctor, and then they'll be referred on to an orthopedic doctor after things like medicines fail. But orthopedists will treat patients non-surgically as well as surgically.
That's really important because I don't think a lot of people do realize that this is, orthopedic surgery does both non-surgical as well as surgical treatment. And I think that's really important to address it. You don't necessarily have to go to your primary care, although you can follow up with an orthopedist who is specialized in this area, who doesn't always do surgery, because I think that's something that's very important. Now we're going to turn here for a second because I want to look at some x-rays that we have, and I want to show you, get you to explain a little bit about these x-rays. And of course right now we've got a normal x-ray. Explain this x-ray a little bit to me so people can kind of understand what they're looking at when their doctor shows them this.
So this is a hip x-ray, and the hip is a ball and a socket. And you can see the ball there, and the socket is that little white line above the ball, and there's some space between the white line and the edge of the ball, and that space is cartilage. And so this is a normal hip x-ray.
Okay. Well, now I want to go to the next one, because now we're going to have one that's a little bit, it's obviously different. And this is severe. DJD stands for degenerative joint disease. So this is severe degenerative joint disease. Describe this one to me.
So the big difference here is you don't see that space between the edge of the ball and the socket. So that white line that was the socket is touching the edge of the ball. So there's no more cushion in this hip joint.
Okay, now we're going to go and look at normal again. This is a little different x-ray. You can again see that white line that you're talking about. Describe this one to me. It's just a little different look at it.
A little bit different view, but again, the ball is there, and then there's a space, and then there's the white line, which is the socket. And so there's some cartilage between the ball and the socket in that x-ray.
Okay, then we're going to go to this next one. This is that same x-ray, or same view, just a different patient. Again, severe degenerative joint disease. Describe to me what's going on here.
And these are similar findings here. You again do not have a space between the ball and the socket, so all of the cartilage is gone in this hip.
And that's what's causing the pain.
Correct.
And that's going to make it also a decrease in their motion, is that correct? Because they can't move that hip as well?
Correct.
Okay. We're going to take a break right now. We'll be right back. When we come back, we're going to talk a little bit more about how to fix that x-ray that I showed you just a second ago. We'll be right back after these messages. Welcome back to Helping Today's Woman. In the last segment, as we ended, I told you we were going to look at some ways to fix the x-ray that we looked at. Now, we talked about some surgical and some non-surgical options in the last segment. In this segment, we're really going to concentrate on the surgical options. So I want to start off, again, I'm joined by Dr. Matt Barrett, who is a orthopedist at the Tennessee Orthopaedic Alliance who specializes in joint replacement surgery. And Matt, one of the things I want to touch on in this one, if we start, there have been major advancements made in hip replacement surgeries. And I want you to give us a little bit of an idea of what's come on, because I know this is, you know, a much different procedure than it even was 5 years ago. It's much more precise, much more better outcomes. Tell me a little bit about that.
Well, I think major advances come along maybe once every 10 years. I think there are minor advances that come along, you know, yearly. But when I think of major advances, I think of changes in the way we put the parts in. Like, for instance, when hip replacement first started, the parts were glued in.
Right.
And then we went away from that because that failed, and we went over to cementless implants where there is no glue. That's a major breakthrough. It made a difference in years and years of survival. So that's a major advance. There's been major advances in the quality of the plastics that we use. Mm-hmm. Those have made tremendous differences in the longevity of the implants. And then there are minor advances. You know, we've had computer-assisted surgery recently that has helped with alignment of implants, and hopefully that's going to translate into longer lifetime and lifespan of the implant. We've had minimally invasive surgery, and we still don't know what the long-term benefits of some of these newer things will be, but I would qualify those as minor advances compared to the things I mentioned earlier.
Interesting, because I would have thought you would say the computer-assisted was a major advance. So, you know, as being an OB, I don't necessarily deal with this. I'm interested to hear you say you think that's a minor advance, and I understand the glueless is a huge advance. There's no question. I've heard that for a long time. All right, we're going to move on a little bit. I want to look at these. The next thing we're going to look at is some of the new implants, because we've got some implants here, and I want people to begin to understand a little bit about what these implants are and kind of how they work. So let's take a look at them. So describe to me a little bit what you got in your hand, first of all.
Well, this is the stem of a hip implant, and this goes down into the femur bone. It's kind of like a spike that goes into the femur bone. A ball mates with that stem and locks into place there. This cup is kind of like a metal sponge. The bone grows into that part, and that goes up into the old socket. And so then this is the hip replacement. So you have almost a frictionless environment there. And so this is a typical hip replacement with a metal ball on a plastic socket.
Interesting, because you know, this is where, from what we were looking at earlier, this is your biggest issue, is this ball with basically this removed, so you're now on this metal part. having the plastic allows much more motion of the hip, correct?
Well, this is where the bearing surface is. This is where the motion occurs. Now, we've got newer bearing surfaces, and we have polished metals so much that you can now place a metal ball on a metal shell.
Interesting. Okay.
And so this is a newer type hip replacement here, and so you have a metal ball that articulates with a polished metal shell, and so there's no plastic in this hip replacement.
Now, what's the advantage of this one versus this one?
Well, the proposed advantage is that the plastic won't wear out because there is no plastic. Historically, the plastic would wear out in a hip replacement, and the idea was to try to make something that wouldn't wear out. And so we came up with metal implants, metal on metal. We came up with ceramic implants, and this is a ceramic ball.
Okay.
And the hope is that those would wear less than metal on plastic.
Okay. Has that been proven, or do we know yet?
It has been proven somewhat, but the plastic has been improved so much that the wear of a metal on plastic is actually quite similar to the metal on metal and the ceramics.
Okay. Now that we've done our surgery, we've put one of these, whether it's metal on metal or metal on plastic, and they're coming out of the operating room. Tell me what they can expect in that immediate post-operative period. What kind of things can they expect in those first couple of days in the hospital? What do they expect to be happening? Well,
typically, I allow my patient to rest that same day of surgery, and then the very next morning we get up and we start walking, and so we start physical therapy the very next day. We give pain medicine so that it's more comfortable, but therapy begins almost immediately with the hips.
And so how quickly, they're going to get up and walk probably the night after surgery?
They get up and walk the morning after surgery, and so there's very little downtime. You're up walking almost immediately.
That's great. Is that a change from the way we used to do them?
It really has. There's more emphasis on getting people moving quicker.
Well, and I know that's pretty much, even in my surgeries, people are surprised as to how quickly we get them moving. But I know that's been a huge issue, and it'll be a huge issue in survival rates and actually how patients do in surgery. You agree?
I would agree. You have less risk of blood clots and pneumonia and all those type things if you're up moving immediately.
Good. Now, next question is, how many days, a lot of people want to know, how long am I going to be in the hospital? If I have this procedure done, how long am I going to be in the hospital afterwards?
The average stay is usually 2 to 3 days, and an older patient may stay 3 days, a younger patient may stay 1 or 2 days, so a little bit of variation, but on average about 2.5 days.
Now, the other question I have for you, because we had this discussion before we went on, is some people will go home, some people will go to a rehab center, and some people will go to the outpatient center at Charles. Describe to me what patients can expect. The majority of your patients, do they go home? Do they go to a rehab center?
I think the most important factor on that is how debilitated the person was before the surgery. So if they were barely able to walk and were spending most of their time in a wheelchair, they may need to go into a rehab center for a while in order to get moving again. If they were able to walk and function, they very well may be able to do outpatient therapy, which is where you go home and then you get in your car and you ride to outpatient therapy 2 or 3 times a week. So there's some variation there.
And there are still people who will have physical therapy at their own home, is that correct?
Correct.
Because I know that's what my mom did. She had it actually at home and made it easier. The other thing is they also, I know in Dallas they offered occupational therapy because mom had some issues. People don't think about even grabbing things, getting up and down from the toilet. These are all issues that people don't think about with new hip replacements, but they're issues they have to think about, aren't they?
Correct. I have an occupational therapist see every one of my patients, and it just helps them get ready for being at home and being able to better take care of themselves and function.
Good. Now, we're going to take a break, and after these messages, we're very lucky to have a patient who has recently undergone this procedure. She's going to discuss with us a little bit about her experience with hip replacement surgery. We'll be right back after these messages. Welcome back to Health in Today's Woman. Tonight we are discussing hip replacement surgery. In our first 2 segments, we really focused on not only the patients that are best advantaged by the surgery, we also looked at some of the surgical advantages that have occurred. In this segment, I want to take a real-life look at somebody who's actually had the surgery done and learn a little bit from her experience. In order to do that, I've invited Miss Gloria Kane, who had hip replacement surgery approximately 6 weeks ago by Dr. Barrett, who's again joining us today. I want to ask you a little bit, Gloria, about your experience so that we can help other people understand kind of what led you to do this. So why don't we start there? What led you to approach Dr. Barrett about doing this procedure?
I fell on black ice and ignored it, like nurses do, and developed a limp, but still didn't go in to see him. I waited about 7 weeks and then went in to see him, and he did say at that time that the only choice would be hip replacement.
Now, did you have a break or no?
No, it was not a break. I had poor circulation in that bone, and it kind of crushed it, which took all the cushion away.
That's interesting, because when we looked at the x-rays earlier, because we were talking about this a minute ago, interestingly enough, in the x-rays we talked about basically arthritis, which is narrowing of the joint. This is another reason to get hip replacement. So it's not always arthritis, correct, Matt? There are lots of reasons to get hip replacement surgery. Okay, go ahead, I'm sorry. You went in and saw him, and then he said, this is my only option.
Right, and then I waited until he had an opening, and, and then we had the surgery done April 11th.
And were you getting around at the time, or were you really having to limp, or before the surgery?
I had a bad limp before the surgery.
But you were able to actually walk?
I could walk, but I did walk with a cane.
You did, and you'd never
Just
done
for
that
support,
before.
never done that before.
Now, one of the things you have to understand about Miss Gloria is she worked 20 years in the cardiac cath lab at Middle Tennessee Medical Center, so she's a very active lady, and my guess is it was not easy for her to walk on a cane. Is that
That's
correct?
Right.
I would kind of bet that. Let me kind of turn a little bit here, because I want to talk to you a little bit about, I want to highlight something, and I just did a little bit. You're an active lady.
Yes.
And people don't think necessarily of hip replacement surgery being done on somebody who's an active person. They think it's done on the elderly, convalescent, maybe in the nursing home, or is in their 80s. It's not, is it? You're not that.
That's right.
And did that surprise you when he said, you know what, you're going to need hip replacement surgery?
Yes, it did.
And and obviously I think you're glad you did it now.
Oh, yes.
Now, Matt, I want you to address this too, because I think this is something that's very important. Not everybody who needs hip replacement surgery, A, has arthritis, or B, is convalescent and sitting in a wheelchair in the corner. Is that correct?
That's correct. There's several different diagnoses that can lead to joint replacement, but you have patients who are teenagers who need joint replacement, and you have people who are in their 90s who need joint replacement. So there's a wide variation, but in general there's been a trend toward joint replacement in younger people, more so than in years past, and that's because a lot of the implants are lasting longer than they did at one time.
And that's what I was just thinking when you said that. It's these young people. It is very important, especially in young people, that these implants last longer, because they've got their whole lives to live.
Correct.
And how long is the average implant lasting now?
I usually tell folks that there's about an 80% chance that it'll last 20 years, and so probably 8 out of 10 of them are going to last 20 years.
That's great. Now, going back to you, Gail, I want to get a little bit more about your history. Now, when you left the hospital, Matt and I were talking, so you did not go to a rehab center, and you honestly didn't even do home health.
No.
You actually drove to the hospital, and you told me why. Tell everybody why you drove to the hospital.
I just couldn't be locked up in a house for any time. I needed to get out and move and keep active.
And since you've had the hip surgery, have you been able to do the things that you wanted to do before?
Yes, yes.
How long did it take you to get to where you were actually able to get out? Obviously, if you're going to rehab, you were probably going pretty close to the end of surgery. You were in the hospital for what, 3 or 4 days?
2.5 days.
Okay, and then you probably were going to rehab. How long after that?
5 weeks.
And but you started rehab
the day, 2 days after I came home from the hospital.
So you were leaving your house 4 days after surgery.
Yeah.
That's pretty impressive.
It is.
And that's an amazing part of modern medicine. As Matt and I were talking, we used to keep people, for example, heart patients used to be kept in the bed for 6 weeks, and we never keep anybody in bed overnight, basically. And Matt was saying the following day, it's crazy. We're starting to get people moving and more active, and it makes a huge difference, I think. And just kind of, this last one I want to get to is, I want you to have the chance in these last few minutes, few seconds that we have, what would you change about your procedure pre-op, okay? Anything that you can suggest to anybody that you could have done differently, made it easier for your rehab?
Not really. I'm active, and I enjoyed rehab because it helped me loosen up and get strength back.
And you felt like doing what you did, you would have never needed anything. Had you not had that fall,
Right.
you don't think you would have ever needed anything?
I don't think so.
Interesting. Matt, any suggestions that you have to a patient who can maybe make not only their rehab but their surgery better? Any suggestions?
Yeah, I think the main thing is preparation and getting prepared both at home and from a mental standpoint, and spending time talking with your doctor, doing some reading. And the less unknown you have before you go into something like this, the better off you do. So that's what I would recommend.
We're going to take a break. I have been very blessed to have had Gloria and Matt in this last segment. We'll be right back to wrap up the show. Welcome back to Health in Today's Woman. Tonight we've had a discussion about hip replacement surgery. I have been joined by Dr. Matt Barrett, an orthopedist who specializes in joint replacement surgery at Tennessee Orthopaedic Alliance at Middle Tennessee Medical Center, and Miss Gloria Kane, a nurse at the hospital who has recently undergone hip replacement surgery. So I want to say thank you to them for being willing to be here tonight. I also want to say thank you to you, our viewership. Tonight marks a 2-year anniversary that I have been doing Health in Today's Woman. Our goal when we started this program was to make a difference in medicine. We have been doing this for the last 2 years, and I hope we continue to make a positive impact in medicine for years to come. Thank you and good night.